Good afternoon, everybody. I'd like to welcome you to Chronic Pain Gains in Alberta. This is our ECHO series. Today, we'll be starting off with our didactic session called Screening for Psychosocial Issues. We just like to acknowledge that we are in Alberta. We are situated on the ancestral territories of many peoples, presently subject to Treaties 6, 7, and 8. And we would just like to acknowledge that all the many First Nations and Métis Inuit people have cared for these lands before us. And we'd like to make this acknowledgement as an act of reconciliation and gratitude for those who have cared for our lands. Today, our session is going to look just a little similar to usual. So we'll be having our session disclosures and some housekeeping items. Then we will go into our presentation by Dr. Sasha Mallya, and then we'll have our case presentation directly at 5:55, and then we'll have our case discussion. So always remember, with our ECHO, we start off with clarifying questions first. So first from the audience and then the hub team. And then at the very end, we go to recommendations. So when you are thinking of anything about the case, please ask your questions first. And then if you have a comment, leave that until we get to the recommendation session. In terms of our disclosures, my name is Dr. Leah Phillips. I'm joined with Dr. Kathy Scrimshaw with Salam Bene and Mallya Mudrik, and we are all paid employees of the Alberta College of Family Physicians. And I'll be your facilitator today. Kathy will be monitoring the chat for any questions, and Salam and Mallya will be helping us with some of the technical aspects and with our speakers. And just in terms of disclosure, all of our speakers today have received a small honorarium from the Alberta College of Family Physicians. And in terms of mitigating bias, our scientific planning committee has looked over the content of our didactic session, and we try our best to mitigate bias whenever we can. The learning objectives are both approved of and looked at by our planning committee, and information in each session tries to be at best evidence-based. However, our discussion section is not part of that same certification issue process, and so those discussions are kept are independent of that, and are of course looked at as independent recommendations. In terms of housekeeping, we'd like to capture your attendance while we're in the session. So please click the survey link in the chat, and you can enter your name and your email address. We prefer that people raise their hands when asking questions. There will be a dedicated Q&A after the session, after the didactic portion, and we will use the chat log to collect questions, but we like it if you raise your hand and ask your question. During the case presentation, there'll be lots of time to ask questions and share information, so we always leave time for that at the end. And again, please fill out the evaluation survey at the end. That will be in the chat log as well, so we can just get your feedback, and we can do some improvement as we go along in these sessions. So in terms of echoing, how do you echo successfully? Echo is one of those great opportunities to work together with your colleagues. We like to be able to see each other and to hear each other. So if you do have a question or would like to make recommendations, please try to turn your camera on if it's safe to do so. Please be kind and respectful to everyone in the session. And remember that ECHO is an all teach, all learn philosophy. So what we do here is just basically we all learn from each other, and we like to share information, and no information is too little or not correct. It's all about how we work together to make sure that our patients get the best care. In terms of introductions, like I said, I introduced our team already. I'll be the facilitator. Our hub team consists of Dr. Ted Finley, Dr. Lori Montgomery, Dr. Kelly Shinkarut, Amy Niels, and Julie Min. I think we're short Julie and Kelly today. I'm not sure. Oh no, Kelly's here, sorry. So we'll get, just everyone could say hi and just wave to everyone in the room. So this is our hub team. This is made up of skilled professionals who provide support by, they'll be asking questions and for clarification and providing recommendations, but that means that the audience also is really would love to hear your recommendations as well. So we'll get started on our session. For our didactic session, first today we have Dr. Mallya, Sasha Mallya. She has completed her PhD at Toronto Metropolitan University, specializing in clinical psychology and neuropsychology. She began with a postdoctoral fellowship at Princess Margaret Cancer Centre within the Pencer Brain Tumor Clinic and Adolescent and Young Adult Oncology Program. She started working at the Calgary Pain Clinic Center in 2019, and her roles include providing pain neuroscience education, providing individual therapy using evidence-based treatments such as CBT, ACT, and mindfulness, and for chronic pain and related mental health concerns, and facilitates group interventions. Dr. Mallya's clinical and research interests focus on the benefits of mindfulness for neurocognitive and psychological health. So I'd like to just say welcome, Sasha, and please take it away. And I will change your slides for you, so just let me know when you need them.
Okay, perfect. We'll start with the title. Thanks very much, Leah. Next. I've got no conflicts of interest to declare. Next. So in my 10 minutes of time, I'm going to share some information that will hopefully help you appreciate the importance of screening for psychosocial variables in folks with chronic pain, learn how to ask about psychosocial factors, and I'll provide some practical scripts and ideas for how to broach these questions. And then I'll give you some further resources at the end. Thanks. Next. All right, so to introduce the topic, we've got patient A and patient B on the screen. Patient A is 43 years old, male. He reports having low back pain for the last 6 months, and he comes with no findings on imaging and no medical comorbidities. Patient B, oh, not yet. Thanks. Patient B is 45 years old, male, low back pain for 5 months, and similarly, no findings on imaging, no medical comorbidities. So with this information alone, may be difficult to have any certainty on who is going to have a better prognosis in terms of their back pain. Now, well, that's what I think. My husband, who is not a healthcare provider, was like, oh, clearly patient B is going to be better. And I was like, why is that? And he's like, look at him. He looks like the guy that's going to get better versus patient A. And so that was his opinion, no medical expertise whatsoever. I thought that was kind of funny, but maybe we do have some biases based on how people look. But with this information alone, I'm trying to get across that it's hard to know who is more likely to get better. Let's ask about some psychosocial factors next. So patient A believes he will get better. He has a supportive spouse. He uses relaxation when he is stressed, and he is financially stable and secure. Next. Patient B believes his pain is a result of God punishing him. His spouse is dismissive of pain, and when he's stressed, he drinks alcohol. The family is also behind on utility bills and mortgage payments. Now, with this additional psychosocial information, most of us can maybe take a guess about who's more likely to have better outcomes in treatment. We can't say for sure, but I think we can probably take a guess. And so this hopefully highlights that, you know, maybe with, yes, Leah, I think that's where my mind was going to. Patient A is probably going to do better in treatment. And so although there may be biological differences that, you know, all the physicians on this call might be able to discern with interventions and tests and medications, different trials, according to the literature, when demographic factors or length of pain is more or less the same, the greater portion of the variance is actually better described by psychosocial factors. So very briefly, this is why we're hoping to, why it's important for everyone to explore psychosocial factors. Next. So the biopsychosocial model of pain perfect, is really the running model for chronic pain. Really all health issues we should be considering as in the context of the biopsychosocial model, and simply looking at the biological factors leaves out very important pieces of the puzzle. And so the goal of psychosocial screening is to include the other 2/3 of the pie, as shown in this picture, to identify the relevant emotional, behavioral, social factors that might be contributing to the person's experience or complicating the person's experience. Next. So there are two, maybe seminal is the right word, research articles that I have listed at the end, published in the Journal of Pain, that have summarized some of the most important psychosocial risk factors. The papers overlap in some of their factors. And so for the sake of this 10-minute presentation, I've combined some of them and renamed some of them just to make it a little bit more easy to get through. So I'm going to kind of now give practical examples on how to explore each of these 6 risk factors. Next. So in the next couple of slides, you're going to see a table. On the left is each of the 6 factors. In the middle is an example of a script you might use, and then an explanation for why, according to the literature, we actually ask these questions and explore these factors. So pain duration, I'm sure that's pretty straightforward. Don't need to go into that. Psychopathology. So asking if they've ever been diagnosed with a mental health problem. And then the most frequent psychopathology comorbidities are depression and anxiety and chronic pain. So you might want to specifically ask about those. We also want to ask about past and current exposure to these symptoms or diagnoses. We also know that personality disorders, psychotic symptoms can also place a huge burden on the patient's coping ability. So asking if you have time about all of the mental health diagnoses can be particularly helpful. Sorry, one more, if we could just go back, and substance use. So asking about caffeine, nicotine, cannabis, alcohol, and so on. Asking if there's ever been a problem. Do you currently have a problem? And then also asking about their medication usage. Do you ever take more of a medication than prescribed? Do you take less of your medication than prescribed? Do you use it in a way that's not prescribed? These can all be really helpful questions to ask. Of course, the explanation there, I think, makes sense, that inappropriate substance use predisposes patients toward other maladaptive coping strategies, and medication misuse can certainly complicate their prognosis. Okay, next. Social network. This is so important. Who are your main supports? How have your family members or the other people around you reacted to the pain? I also, as a rule, ask about domestic violence and interpersonal violence. You can imagine that that would complicate someone's pain experience. On the other hand, social contacts who are enablers can also strengthen the identity of passivity and being a victim. So if the person sort of takes what we sometimes call the wait until approach, or I'm not in the mood to do this, or I'll wait until I'm feeling better, or I'll wait until my spouse comes home and they can do it for me, and I'll just rest on the couch until I'm feeling better. If their spouse or whomever is enabling that passive behavior, that creates a bit of a vicious cycle. So just being curious about what the people in their lives do in response to their pain. Are they punitive? Are they dismissive? Are they enabling passive coping strategies? That can really give you an opportunity for intervention from a more systems perspective. Of course, if somebody has no social network, that also contributes to the picture. Trauma and abuse, hopefully we all know that there is a pretty significant relationship and mutual maintenance between trauma and chronic pain. It can be challenging to ask about, but I've given you some examples on how you might broach that topic. And then negative pain beliefs. I think this one's a really interesting one, and actually not one that I spent a lot of time doing in my own practice, but the literature is really interesting on how pain beliefs can impact the pain picture and recovery. So asking the person, what is your theory about what's making you hurt? What do you know about your diagnosis? It kind of, now that I've thought about it, it makes a lot of sense to ask that. But in the first example I gave, if person B thought to themselves, well, I have pain because God is punishing me. Wow, that's a very different theory than someone who says, well, I think maybe I'm overdoing it with activity, or I'm really, my posture is incorrect, and maybe I could do something about that. So negative pain beliefs and catastrophizing absolutely impede recovery and can be another interesting point of intervention for you. Okay, next. So that is the long version. If you've got lots of time, I spend 90 minutes to 2 hours. I'm a clinical psychologist, so I get a lot of time screening for psychosocial issues, really able to go into depth. I know that my physician colleagues at the Chronic Pain Center get a lot of time to do assessments with patients, and then ultimately know that they can refer to a psychologist for deeper assessment if necessary. But I can also appreciate that not everyone has that luxury. And so there is a brief psychosocial screening strategy for physicians, designed by physicians to screen for these factors. It's called the ACT UP model. And so it kind of tries to give you brief strategies or questions for asking about these issues, asking about their activities. How is pain affecting your life, sleep, appetite, and so on? How are you coping? What do you think about your pain? Do you think it will get better? Are you feeling upset by your pain? Are you worried, anxious, depressed, down, or blue? And how do people around you respond when you have pain? So it really just touches on this, but it's better than nothing. It's like immensely better than nothing. And I know I'm a psychologist, so I'm biased to all the psychosocial factors, but I'm hoping that all of you will also see the importance of the psychosocial factors being just as important as the biological factors. So this is your brief psychosocial screening if you don't have the time to go into all that other stuff. I've given you the reference down there in case you can't write this down as fast as you want. I think you'll also get access to the slides, so you can always go back. Oh, next, please. I can't go next. So in closing, I think I've hit this nail on the head a few times, but biological factors are just one piece of the chronic pain puzzle. Evidence consistently shows that psychosocial factors contribute not only to the development of chronic pain, but the consequences of chronic pain, and are important for predicting the outcomes of treatment. And by screening for psychosocial factors, we increase our opportunities for not just connection and building rapport with our patient, which evidence also shows is important for prognosis, but also it gives us opportunities for intervention. All of these areas that we can start to intervene when it feels like the medical interventions aren't working, the medication trials aren't working, the tests aren't showing anything new. Well, the psychosocial factors may be the last piece, the piece that has the biggest impact. Next, please. So the Chronic Pain Center website has educational videos on pain neuroscience and the biopsychosocial model of pain that anyone can access and can help both providers and patients learn about these factors. So on your screen, at least on my screen, the URL there is like pretty tiny, but hopefully you can see that okay. And then finally, please, last slide. are some of the key references for you if you want to do some more research. So the Edwards 2016 and the Turk 2016 papers are the one that really dive into psychosocial factors for chronic pain. And that's everything. Thanks very much. Happy to take your questions.
Thanks, Dr. Mallya. Yeah, we have 5 minutes for questions if anybody has anything they'd like to ask. I'll just remind everyone too that Dr. Hendricks is giving our presentation, our case presentation today, and he will need to be leaving right at 5:30, so we'll have to be quick with our case and our recommendations today. But Bill, do you have a question?
Yeah, so we're working on something in the clinic called social determinants of health, which really falls into this thing, because if we really look at where we are at in our society right now, it's the social determinants of health which falls into all of this play that determines how patients will do in the end. So is there a lot of literature on how this all relates to the social determinants of health?
That's a great question. I'm aware of that term, but in my preparation for this presentation, and I think in my general training, I feel like at least in my training, that was a whole other section of work that I actually wasn't really involved in. But my understanding, like you said, is that there's so much overlap that these factors are certainly important in treatment and just consideration for all of our patients. But I'm not sure if I can answer your question specifically about the literature.
I think one of the things I'd note is that the social determinants of health really is a public health type of term. So not based on individual treatment, but as a whole, these social determinants do make a huge impact in the system of our health system. So for instance, poverty. And but as a patient, if you are poor, that is certainly a social factor, but as a system, it would be poverty as a whole that would be the social determinant. So there are these things within our society that do make the general health of a population worse. And so that's how I kind of see the difference between these psychosocial factors versus social determinants and psychological determinants, I suppose. But they're more social because of like education and that kind of thing that are much more broader on a population level. That's how I learned it in my PhD in public health. So
okay, that's helpful. Thanks, Leah.
Lori, go ahead, please.
Thanks. Yeah, I was just going to say when it comes to the pain literature, there are a couple of review articles, especially in the last 2 or 3 years in the journal Pain. There have been a couple of review articles on social determinants of health and pain. But generally speaking, in the literature, it's broken down, so there are lots of studies on poverty and the effect on pain. There are lots of studies on adverse childhood experiences and pain. Not the umbrella term, social determinants of health, but breaking it down into those contributors, then there's all kinds of pain literature.
We do have a question in our chat. The question is, are you treating psychosocial chronic pain with cannabinoid? Is that correct? The way that's saying it right?
So as a psychologist, I'm not suggesting any substances at all, but maybe my hub team colleagues or even anyone else on the call might have a comment about that. I'm not sure what psychosocial chronic pain might refer to and how that might be different from another form of chronic pain that you might be thinking of.
I was thinking actually too, while you were giving your talk, is that we often always only talk about risk factors that are in the negative instead of kind of what are the protective factors for chronic pain. And they're not sometimes just the inverse of those, so you're catastrophizing. Well, you're not catastrophizing, but is it that you have a healthy potential kind of expectation for recovery, or that you are, you have a good mindset on your own body, we barely do any studies looking at kind of things that are more in the positive kind of, instead of risk factors, what are the protective factors for going, having chronic pain? And I guess just wondering if you suggest looking at some of those things too. And when you see patients, what kind of things that would you say, oh, this person has probably a good chance of recovery?
Mm-hmm. Yeah, so I think the beliefs of or the theory of pain, actually, now that I thought about it more, it really is a big one. What do you think, is underlying your pain, or what's your theory about why you hurt, is such a powerful one. It can be so protective when they can, talk about active pain coping strategies. That I think is another one. Having an understanding of pain neuroscience, I think, is so protective. A positive, helpful, supportive social network is so beneficial. What are some other things that come to mind? I think openness to experience is a big one. What else? Resilience, having a history of resilience to other difficulties in life stands out. And one thing I also, on that note, ask patients to think about is not just the factors that make their pain worse, but the factors that make their pain better. And what are those safety messages in their lives? What are the smells that actually make them feel better? Who are the people that make them feel better? What are the places that make them feel better? And we talk a lot about the danger messages and the safety messages, and that cultivating safety messages is equally important to eliminating or modifying or avoiding the danger messages. So also just kind of going in that route of positive experiences and helpful experiences, not just focusing on getting rid of all the bad stuff. That's a great point.
Thanks. And Kelly, we have maybe one short question, then we have to start our presentation.
This is actually just in response. I was thinking about this question in the chat box about treating psychosocial chronic. I was wondering if the question was more about those patients that come with histories of anxiety or other concerns that are contributing. I'm not sure if that's what the question is about. But in that case, I mean, how long will it take to heal a patient from psychotherapy? Oh, that's a good question, Sasha. I was going to say, just to finish off my last little bit, but we certainly don't treat things like anxiety and depression exclusively with cannabinoids. I think we would look to see if there was any kind of indication or role for cannabinoids, and yeah, solely like psychiatric or mental health disorders would not be an indication for cannabinoids. I'm not sure if that's an answer that